And good afternoon. Thank you, Joy, for the introduction, and thank you to Dr. Link for being here. One thing that we want to just try to emphasize in terms of the scope here, this is a unique opportunity with an expert in charge of the single IRB overseeing the StrokeNet studies, is to really focus not on general IRB issues, but IRB issues that are unique to the research that we do in neurology and neurologic conditions. So just with that lens, again, we'll certainly work to address any questions, but if we try to keep our focus there, I think we have a unique opportunity to think about some of the interesting things here. I've done more to hopefully optimize the sound of this. So again, we will, without further ado, I'm going to hit a few of the high points of the talk we had. And then there have been some changes since 2016, so we'll talk about some of them. But I think some of the topics that are most long-lasting and pertaining to neurology are some of the bits that I've highlighted from the video.
And then just remember that when there is no known therapy or limited therapy, virtually every clinical decision you make is experimental. It's hard to then not look at a new study and totally think of it as research versus clinical care. We also give a lot of mixed messages. You know, is it research or is this cutting edge medical care? Think back to my example of the Guillain-Barré. You know, what if in the same hospital you have one person or one clinic who's actually giving the new Guillain-Barré treatment, whereas maybe across the street in a sister hospital is only done as research. I think as subspecialties, we are not always clear as to what we are purporting is research versus this is extraordinary medical care. There are also terms called therapeutic and non-therapeutic research. And again, therapeutic research would certainly suggest that this is clinical care. And this really falls in primarily with a lot of cancer studies. And the question does get raised, you know, a lot of people will think a phase 2 cancer study is therapeutic. How about a phase 1? A phase 1 cancer study is different than other phase 1 studies. I don't have the answers for this, but you will definitely see these terms around. And then when we say to people, well, why didn't they realize this was research and this wasn't care? Again, you can see why perhaps people fall into this. I already talked about the reimbursement. The other issue is participants get confused as to, is this research, is this care? If they see a doctor asking for the consent form, looks like a doctor, must be a doctor, must be care. And the other thing to remember is the participants, as a rule, have very poor memories for what they signed up for. A lot of that is, I think, our consent forms are oftentimes not very good. The process may not be good. And people just remember what it is they're getting as opposed to all of the elements of the consent form. And I think if you're coming into the hospital with a chronic or an acute disease, it's going to require a lot of clinical decision making. And then you kind of intersperse in there some research questions. It can be very difficult for an individual to keep that all straight, particularly the same person or a same looking person explained and got consent for all of them. Again, that says the same thing. Okay. So presenting risk. I already alluded to the fact that the risk itself, as well as how people hear about risk, really depends on where you're starting from. But who is the source of the information? If it's my mother-in-law, or is it 900 of the smartest neurologists in the country agree on this risk? Very different. The nature of the risk, are we talking a rash? Are we talking bone marrow suppression? Are we talking death? The sensitivity will be different. If the risk is of high consequence, again, you might lose a leg, quite different than you'll have a rash. If everyone who takes this, if you're going to be in the study, you just have to accept that you're going to have a rash and a high fever. It's inescapable. So that's where you got to accept that before, there's enough benefit for me knowing this is going to happen. It's very difficult when you have a brand new procedure or drug that you're looking at, and you really don't know what all the risks are going to be. And I have to say to some, right now, this is the best we know. We'll let you know if new information comes out. And in some studies that go over some period of time, as more is learned about the drug or the process or the device, you may have to go back to participants and say, when you signed up, we said that, there was no liver toxicity to this. Well, now we found out there is. So again, that can be confusing to participants. As you present risk, the best I can say is realize people are going to hear about risk from a lot of sources. You as the investigator will be one source and hopefully seen as the best source, but patients and participants are going to talk to their other health professionals. They're going to have a lot of unofficial experts, many of these on the internet. They listen to the news. They may be those who just say, oh yeah, I believe anything new must be better. So in presenting the risk, it's really, as much as you can, develop trust. Easier if you know the person long term, but really avoid over-promising. If you are presenting risk, realize that certainly our society does have a problem with numeracy in terms of really understanding what numbers mean. So oftentimes, graphs or comparisons work much better. I'm going to ignore that one for a moment. And we already talked, I think, ad nauseum for you poor guys, the extension of usual care. For the desperate patient, I already said they're already convinced that there's a benefit. They may not want to hear about the risks, but you have to go through them. If they see no other options, they don't want to hear about it. And many are pushed into this battle metaphor. We're fighting your cancer, we're fighting your ALS. And it's interesting, some patients have come back and said they hate that metaphor because they fear if they say, no, I don't want to do this, they're seen as a quitter. And whether clinician also quit on them. So it's a double, edged sword here. Some love it, some don't love it. I just put it here to be aware of it. So your options in the desperate patient, the ALS patient, provide additional protections. Just be aware of these issues. Spend more time really going on. This is voluntary. What are alternatives? What are the risks of this? Okay, may need more time for that. You may need more training. The clinician who's seeing the person may need to be pulled in so that they don't kind of give misinformation back. And everybody here needs training. Or you could avoid all desperate patients, which I'm not suggesting, or refer them elsewhere. Again, these two options are very tongue-in-cheek. First of all, a study of hemorrhagic stroke. Plan ahead. This should not be a surprise when the first participant comes in. So definitely plan ahead. Know your institutional policies, which I already talked to you a bit about. And identify who can give surrogate consent and how can they give surrogate consent. Do they have to be there in person? Will you be calling the wife on the phone? If the person comes in by ambulance with no family members, does that mean that you can't enroll that participant in the study? Or does your IRB allow you to do this by phone? So think ahead of all the possible ways that this may happen. And again, I cannot overstate the need of looking at state and local laws. If you are getting surrogate consent, and if the clinical situation is one in which the competency of that person may return, such as in hemorrhagic stroke, maybe unlike an Alzheimer's patient, the regulations require that once that person regains their competence, they then have to be approached and say, do you want to continue to be in this study? Now, the example I gave of the acute hemorrhagic stroke, if all you did was one infusion within the first 6 hours, clearly they can't say, 2 days later, I don't want to be in that study. But again, if it's a study of longer duration, there might be long-term follow-up. The participant, once they regain competence, has the right to withdraw. So again, that's a key. This is my last slide, I promise. So, in conclusion, I think many of the types of patients that you may ask to participate in research are in desperate situations. There's this obviously spectrum of desperation, both I think the ALS is probably one of the most hideous, but even someone who has a tremor, I mean, you're desperate to get rid of that. And just realize that. I think you as neurologists will see a larger group of desperate patients than many others. I think research with these patients is critical. Recognize that they're vulnerable, and recognize that both your protocol development as well as your conduct of your research may require some additional safeguards and processes to best approach these participants. So I will leave it there, and I'm happy to take questions. I cannot see the question box, so I'll have to have Sam read me if there are any questions. So thanks for your time.
All right, and again, Dr. O'Rourke won't be taking your questions, but we are here. Again, just to sort of reiterate some things, we are going to try to wrap this up by about 12:50, but we're not going to curtail discussion if there is good discussion going on. But we will stop it at 1. We know that people are often on a lot of video calls over the course of the day, but we will try to give you some kind of key takeaway points at the end. And again, I think this is an opportunity to talk to a real expert in the sort of launch of a network and an academic single IRB that's been involved in a broad range of trials in stroke, to think about some of the issues here that pertain to stroke. And whereas Dr. O'Rourke was addressing neurologists, obviously we do have a big tent in the clinical trials methodology course. You don't have to be a neurologist to be part of this, and we know that many researchers from other specialties are focused on neuroscience problems. So with that, as we start to await questions, and again, those can kind of go in the sheet, they can go in the Q&A and in the chat if you have access to the chat. We also have some sort of prepared questions that we can go through. But with that, I think, Dr. Link, you had thought of some things that I think have sort of changed over the past few years. And one of the areas that we didn't cover much are kind of areas of exception from informed consent. So I will hand the mic to you.
Great, thank you, Dr. Muir, William. So you're stuck with me instead of Pearl. Pearl is much more entertaining than I am, yeah, that comes up in terms of lots of studies, but especially in neurology studies, particularly stroke studies, in terms of when you can do a waiver of consent or surrogate consent, or, go all the way to the exception from informed consent regulations, which most of you, I'm sure, are familiar with and are being used much more commonly now than they were back in 2016. We're doing a lot of those exception from informed consent or EFIC studies, which, there's very defined parameters for when those are approvable. But then you have those studies that are in the gray area, and those are the ones we really struggle with, that don't actually qualify for EFIC. They may not be life-threatening. There may be other treatments that are available that wouldn't fit the EFIC criteria, but then, but there are still studies where it's difficult to get an informed consent. It's difficult to get a surrogate informed consent. And currently, the only studies that qualify for a true waiver of informed consent, either FDA or HHS regulated studies, are studies that involve no more than minimal risk. And then you get into debates on what involves minimal risk. So that's still the big issue, though, is that in order to do a waiver, it can't involve, there are other criteria, but the tough one is the one that the study involves no more than minimal risk.
And I think that there's also the sort of idea of the difference, in certain cases there's a waiver, there's certain cases there's the, EFIC process, which, requires, it can be very serious conditions, but it's like the incremental risk of the research procedures has to be at a certain level. So I think that's kind of a key distinction.
Yeah. And that, you know, that gets into the idea of standard of care research. That's a big area of discussion. And if you're comparing two standard of cares, is that more than minimal risk? That's something they would get anyway. That's, you know, that's a whole separate topic of discussion, but that comes into play in neurology research, obviously.
One of the things, though, you know, that can tend to, and again, as some of the others who've been on these webinars know, that I do acute stroke research, and one of the things that sort of becomes a challenge is there's sort of the incumbency of standard care. Like if you were to think of, you know, with time sensitive conditions, and obviously, you know, that's one end of the spectrum. You know, some of the ideas about ALS and having that desperate patient who's kind of declining before their family's eyes on sort of a different end of the spectrum. You know, sort of the acutely desperate patient. There is a balance between sort of biology, right? Like, do we just need to keep using IV TPA forever because it's too hard to do a study to find something that's better, knowing just from a biological perspective, a couple tweaks of a molecule here or there, probably we can find something that's going to bust up more clot, and perhaps do it with less, you know, signaling and other things. But you know, it's harder to find, you know, it's just in general in clinical trials, finding a treatment that's better than placebo is generally easier because new treatments are only incrementally better than established treatments. And secondarily, you know, a consent process in this, you know, world where we really try to treat people with TPA within, you know, 15 to 30 minutes of their arrival in the emergency department, hard to work in, knowing that the downside of the consent process itself is leaving neurons unhappy that they haven't been reperfused. So I guess what sort of thoughts do you have on that sort of scale of things?
Yeah, and you know, those studies probably don't qualify for EFIC now because there is a treatment. You know, one of the requirements for treatment is there's really no EFIC is that there's really no acceptable current standard of care for the condition. Whereas, you know, now you have TPA, may not be the best, but it, you know, it is a treatment. So getting those studies under the EFIC criteria are difficult at the current time unless we start. There's been some movement in the FDA to expand it, but there's been no regulatory changes. So you know, then you're really relying on being able to find a surrogate, and we all know the issues with trying to find that in a timely fashion. So obviously that's a big one of the big areas that researchers struggle with in terms of trying to get informed consent, and you know, and I really don't see those studies going into a minimal risk category. And you know, unless you were comparing two standard of care treatments, and you know that those are difficult. And just because you're comparing two standard of care treatments doesn't necessarily mean it's just minimal risk either. So I'm trying to think of an example of something where we've dealt with that. You know, and then the other issue that I was thinking of is when you're talking about standard of care, not to get all hung up on standard of care, but now with this movement to single IRB review, standard of care varies between different sites, as we all know. So what standard of care at Michigan may not be standard of care in Cincinnati. You know,
yeah, no, famously, since I was a medical student in Cincinnati, when I first started as a stroke fellow at Michigan, I could, you know, I could get an MRI in like 15 minutes at Michigan. It was like one floor below the ER. Whereas at the time in Cincinnati, it involved like a trip through like a freight elevator. And at some point when the freight elevator, which was like 100 years old, broke, involved like an ambulance ride down the street. So like being able to get an acute MRI was quite different in Ann Arbor and Cincinnati in that situation. So there's a question from one of the participants. Since TPA is FDA approved, is it even possible to have a clinical trial where patients are not offered treatment with it if they qualify? How does it work ethically and with potentially not having litigation if the treatment isn't offered? I think you wouldn't be controlling a new treatment against control. It would be the standard therapy. So TPA versus TNK, for example, or some new molecule. You could not, when there is a standard care treatment, you could not ethically have a placebo group, but that doesn't mean you couldn't have comparisons to a current FDA approved treatment, knowing that you have to, you have to make sure you're upfront with people that this is a new, different experimental thing. And I think that also goes to Dr. O'Rourke's comments about sometimes people are like cutting edge, that you get perhaps a little bit into the therapeutic misconception that because we're studying the new shiny drug, it must be better than the old drug, which we obviously don't know. That's why we're doing the research. But if we don't do that research, then we never find the new drugs. So it kind of hits on some of those issues.
Yeah, to do a placebo-controlled study in that setting would be very difficult ethically. And even, I think, most IRBs would want to know why you couldn't do whatever the investigational treatment would be in addition to the standard of care TPA. And there are reasons, and as Will points out, it could be approved and meet the criteria for approval, but not a placebo-controlled study in that situation. Not with a condition that's so serious. There are placebo-controlled studies in areas where there are approved treatments where it's not quite as a serious of a situation.
And you find that sometimes in pain research, in that obviously, and also that there is a strong evidence of a placebo effect. So
right. Psychiatry sees it a lot too.
Right. Yeah, no, that there's sometimes lead-in periods and sort of crossover that you're not
right.
You're not exactly withholding treatment, but it may be delayed based on the timing of the design and so forth.
Yeah.
I think another question, and I think we won't spend all the time on acute stuff, but another question is in a situation where somebody may be on the boundaries of, and this kind of comes up to surrogates and possibly in an emergency situation. How do you assess when somebody has a new thing going on, whether it's TBI, stroke, or some other acute neurologic event? How do you assess whether they still have the capacity to consent to research? I think there's certainly areas on both ends where it's like they seem totally fine to do that versus they seem totally not fine to do that. Right. I guess what's your experience in terms of how do you operationalize that sort of thing?
It varies from study to study. Some studies have a very rigorous evaluation of a participant to determine whether or not they're actually able to provide consent. If it is more of a gray area, maybe Alzheimer's, something like that, early Alzheimer's, and they'll have, they do the MOCAs and they do some type of testing. But then in terms of ICH, there isn't a whole lot of documentation that needs to be made that an ICH patient is cognitively impaired and would require a surrogate. And then in between that is the assent question, because even though we've approved surrogate consent, we would usually like to see assent from the person. And that even gets harder in terms of determining when assent is available. For the stroke study nets, we went through it on the stroke net studies, and even the acute ones, not so much the acute ones, more the rehab types of studies. And we've kind of left that up to the individual investigators to document, note to file or something that they've evaluated the person and determined they weren't able to provide consent, and they weren't able to provide assent, or they did provide assent. The one is the sleep smart study that's being done out of Michigan. And we had a long discussion with them about assent, because a lot of the board members felt that some of these people would be able to provide assent. But they made a great case for that study. there's issues with aphasia, you know, those types of things, and communicating, and maybe a formal assent wasn't possible. But for that study, they made a good argument because it involves CPAP. It's pretty involved. And basically, if the person really didn't want to be in it, they'd be so resistant, they wouldn't be able to be in it anyway. Right.
Right.
Yeah.
Right. Yeah. No, that the compliance, like if even if they're aphasic, if they have strength in the other arm, they'll manage to localize and remove the intervention.
Yeah.
But
there's a whole range of how we determine what we require for determining whether or not someone is able to provide informed consent, and it depends on the condition under study.
And I think it can be quite dynamic. I know that Jeff Saver and others who were involved in FastMag have sort of interesting stories of people who are very early on in their ICH who then had deterioration with the swelling, and that some, you know, there may be a limited window, which kind of bridges a little bit to sort of like a sort of secondary comment of, even if your cognition is maintained, I guess if you are faced with an existential crisis, like let's say I just had a C5 spinal cord injury, my brain's good, but I am now the desperate patient that Dr. O'Rourke was talking about, and you need to start a time-sensitive therapy to protect my spinal cord. I'm in a pretty vulnerable state. I'm probably going to say yes to just about anything. Can you have a real consent conversation with somebody there? But can you really involve a surrogate when, you know, cognition and communication is completely intact?
Yeah, that situation would require quite an extensive justification for why that person wouldn't be able to provide informed consent. But that raises the other issue of, you know, are we really better off expanding the EFIC criteria and going through a very vetted process to get these studies approved, rather than trying to get informed consent from people who are in a situation that they're really difficult to obtain informed consent from them?
Right, right. You almost think of it like, is this in terms of EFIC studies? Oftentimes, there is a matter of, you know, not necessarily bystanders, but there is the potential for assent in those who can assent. That, or at least, you know, like similar to the CPAP example, if somebody feels strongly that they don't want to be in research, there's the potential for that voice, even if they might not be able to fully consent into research under the current regs, the ability to say no. Or, you know, again, I've sort of said that amongst my parents, you know, my dad like sort of wants to like donate his body to science and stuff, whereas my mom is very suspicious of doctors. And, you know, I don't, you know, so if she was in a, you know, if somebody was asking me if she wanted to be in a research study, I would probably say no. But you know, on
that's
my
a
dad's
great
case,
point, because you're supposed to consider what that person you're providing consent for would want, and that varies.
Right, and not what I would want.
No. And that's also a big area that varies from state to state in terms of who's considered an LAR, and so that comes up a lot in the single IRB world.
Oh, for sure, that is there's quite a lot going on with that. So I think to switch gears a little bit, so we're not completely focused on acute care research, thinking more of chronic neurologic conditions that perhaps are progressive. What are some of the key issues there in terms of designing your study, your consent process, and what IRBs think about in review for chronic progressive conditions that could?
Yeah, and you know, I think the obvious one is that monitoring people's ability to continue to provide informed consent while they're on the study, as they deteriorate on the study, and make sure there are plans in place to continue the consent process during the study, and then have a plan if the person loses the ability to provide consent to be able to get surrogate consent. We have a fairly active Parkinson's disease group here, and those types of studies, we deal with that. And a lot of times they identify a caregiver up front that's involved in the consent process. And so that's one of the big things with those types of studies is making sure that they continue to be able to provide informed consent and understand the study. And if they don't, then you move to a surrogate consent. We had an interesting proposed study. It never came through. I think it was a Parkinson's disease study, and they were going to do an implant. And there was some indication that this implant was going to work, and it had at least good preliminary evidence to show it might work. But then once the study was over, they were going to take the implant out. So even if it was working, I don't think that study was never formally submitted. We reviewed it informally, but that would have been a real challenge in that type of work. If something is working and according to the protocol, you're going to take it out at the certain time.
I think another thing that we want to think about is also issues for pediatric studies, childhood neurologic conditions. What are some special considerations in cases like that?
Yeah, so there's a whole set of separate regulations for working with minors, Subpart D of the Common Rule, and FDA has similar studies. And we have approved a study with minors through StrokeNet. And we actually, since we are based at we worked with Cincinnati Children's Hospital, IRB, across the street in order to have expertise in terms of reviewing minor research on that study. But the main thing you're looking at there is the level of risk, because the level of risk changes the requirements for the study. If there's more than minimal risk and direct benefit, you really only have to have one parent or guardian sign for to provide consent for the minor. If it's more than minimal risk with no potential direct benefit, then you're going to have to probably get two people to sign. And then again, it's similar to the cognitively impaired situation. You have to decide when you can get assent. And that's a difficult thing with minors in terms of their age. Some places have a set age, 6 years and older, you're supposed to try to get assent. Other people, again, vary from study to study. So there's issues of payments that come into play when you start using minors in studies, and who's going to get the payment, and what's the potential for undue influence of a parent to enroll their child. Oh, he's got bugs. A child to enroll in a study. With those types of discussions get interesting sometimes. Minors, another issue that comes up, and this, when I'm talking about it now, it's very similar to cognitively impaired, because sometimes long-term studies with minors, they may turn 18 while they're on the study, and then they have to provide their own consent at that point. You have to consent the actual participant in the study if they turn 18 while on the study. At most states, some states it's different, but 18 is usually the accepted age for adults.
Dr. Conwit from NINDS was interested in knowing a little bit more about pediatric stroke study. Is it like an acute study, or what sorts of
the one we're doing is a rehab study. It involves the restraint, where you put the restraint on one arm, and so that one, we have not done any acute pediatric stroke studies yet. In fact, before I was in StrokeNet, I didn't even realize there were pediatric strokes. But yeah, so the one we're doing is a rehab study.
And we think sometimes kids can be in very dynamic social situations, and that can play into recruitment and retention. I think it was interesting that in certain situations there may be the need for two parents who maybe are not too happy with each other any longer. Yeah. I guess what sorts of things, or one could consent initially, and then another might not be as willing to bring to follow-up visits. Any guidance or wisdom there, or a little too early to say as your foray into pediatric studies is relatively nascent, at least at the Cincinnati IRB?
Yeah, we haven't heard of any major problems along those lines with the current study we're doing, and we've done other studies in the past. We have a fairly active pediatric psychiatric department that actually operates out of UC instead of Children's, but it does come up, and one of the requirements is if the other person isn't readily available. We get a lot of questions on that. What isn't readily available? And those are those case-by-case basis, the kind of questions I used to ask my teachers in school. You really have to work through them individually. There's no real good guidance on how to handle those situations, and I rely pretty heavily on the investigators to be able to evaluate those situations. They're the ones who are there working with the people on a daily basis, and like anything else, you just want to document why you made a decision and have a good rationale for it and a basis for why you made a decision. And you can do ethics studies with minors also. I mean, the minors are not accepted are allowed to be in ethics studies, are not excluded from ethics studies. So there have been some of those.
Another thing that is I think something that is interesting is the increasing use of genetics in conjunction with research and clinical trials. I guess what aspects of obtaining genetic information are particularly salient for the IRB review of neurologic studies?
One of the difficult pieces of those reviews is to just be able to explain what they're doing to the participants in a lay language, and what it means of what, if they find genetic mutations, those types of things. So we've developed some, hopefully, what we think is fairly good lay language in the first place to allow people to understand that. And then, you have to get into the idea of whether the issue of whether or not they're going to return the results, and then how they're going to return the results. For some of these, we've required that a genetic counselor be involved in returning the results to people. You have to, obviously, we all understand that, but you have to be very careful in providing this information to people, and then, how it's going to affect relatives, and who's going to tell them, how that's going to be worked out. And then the risks of the genetic testing in terms of what it could mean to your insurability or employability and those types of things. We usually, it seems like those are a separate consent, or at least an addendum to the main consent form, so people can opt in or opt out of those. Occasionally, they're required pieces of a study. If you're doing a genetic study, it's a required piece. But if it's just more of a biobanking type of thing, a lot of times then those are optional.
Yeah, I mean, there can be, it's interesting. I mean, this is like, probably too much information, but like there can be a lot of these sort of downstream effects in that, I have a child who is undergoing some genetic testing for autism. And, when you do that sort of fishing expedition, then, something shows up. So there was he was a carrier for an SMA genotype. But then we felt sort of a duty to warn, like, our siblings, just so that they could be tested. But it turned out that his, and then it was like, so me and my wife, we got tested. But then, we were both negative. So then they called my wife and were like, are you sure he's the guy?
Right.
And it turned out that it was most likely a spontaneous mutation.
Yeah.
But again, I mean, this is all sort of these sorts of downstream things that come. I guess some of the other things, though, some mutations, particularly neurodegenerative conditions, how do you deal with something where like a kid might not want to know what their result is? How would you deal with sort of the parent has to decide? This is sort of, instead of deciding what my disabled parent would want, sort of going forward, like me deciding what my 18-year-old kid would want. if I'm, say, doing a test for Huntington's or something like that, would he want to know, would we want to have that information? Are there examples of those sorts of situations in terms of sort of the right not to know about your genetic material?
Yeah, I mean, the approach that we're taking now in those situations is that however you're going to proceed, it needs to be well described in the protocol. How you're going to tell someone, if you're going to tell them, what if they don't want to know? All of that, we try to get it worked out in the protocol ahead of time so these things don't just get, it's not a surprise when it happens. So really having information in the protocol. Currently the guidance is that there's a number of, I don't remember the current number of actionable, genetic mutations. And those are something that people really need to consider telling the participants about. We wouldn't force them to necessarily, but either way, it needs to be described in the protocol how they were going to be handled. And then in the situation of a minor, obviously the parent makes a decision on whether or not they tell the minor. However, going back to the idea of a minor turning 18 while on a study, then the minor would make the decision for themselves if they turned 18 while on a study. So trying really to be able to have a plan makes this much better to deal with in terms of what you're going to tell people and how you're going to tell them, and the usefulness of that information. We're dealing with it now, not to get too far out, but we're dealing with it now with a COVID seroprevalence study, whether or not you should tell people the results of their antibody tests, since no one really knows what they mean.
Oh, right. There's the uncertainty regarding the value of the information and what it means, and could it change behavior? And that's again, for members of the attendance list, if you have questions, please pop those either in the chat or the Q&A box. We will look for those. The ideas, I think, of genetic testing, I think dovetail nicely with another general area, since many neurologically focused studies include imaging that may only be being done for research purposes. What is a good ethical schema for dealing with incidental findings, again, some of which may have clear significance, many of which may have unclear significance?
Yeah, that got a lot of talk about 10 years or so ago, especially with MRIs and people doing MRIs and even doing MRIs on normal controls, and people thinking that one of the advantages of going into this study is they're going to get a free MRI. Well, that may not be the best thing, right? So again, I'm being a little repetitive, but we want it described in the consent form how you're going to handle those incidental findings. We have template language for our consent forms that basically says, depending on the situation, this MRI is being done for research purposes. One extreme is it's not going to be evaluated by a radiologist, and you will not be told the results of the scan. And then the other extreme is that they will have a radiologist read it, and if they find something disconcerting, you will be notified. But then we also have language in the risk section of a consent form in that situation that's a risk of going in this study, because they find something, it's going to probably have to be worked up, you're going to worry, and it may be nothing. And now you've probably incurred some expense and some angst, and so the MRI findings is something, and it's it's common. It's not that uncommon. You do an MRI and so you see something. So again, having a plan in place and how the incidental findings will be handled is important. We haven't been dealing with that as much in the acute stroke studies anyway, because the argument or the discussion we have with the investigators that these people have so many scans that the odds of finding an incidental finding are low. So, but more where you're scanning people that hadn't had a lot of scans, and becomes more of an issue.
Right, in a study where that somebody wouldn't have had neuroimaging to understand the phenotype to qualify.
Yeah.
All right, if I don't see any other questions, then I wanted, oh wait, here's another, here's one. All right, are there, yeah, so like thinking of older adults, are there specific consent issues that pertain to or older adults in particular? Like, I think the, you know, maybe an example is if there's very long consent form. I guess I shouldn't go there, right? Like if I want to try to finish early, like consent forms are too long.
Yeah.
I'm probably preaching to the choir, but
Yes.
like I think the there was a question about, are there situations where you might are there situations that could arise in research where you might need a clinical bioethics consult to help guide you, or is that really sort of out of their scope? This is really more IRB oversight. IRB will be the arbiter of ethics for a protocol that's under their supervision.
Yeah, I think that's kind of the thought on a clinical bioethics consult on a research study. And I don't know if any of you have had experience trying to use those on a research study, but in my experience, they kind of punt to the IRB in that situation. And I don't, you know, older adults, you know, I think you're still just getting into the issue of determining whether or not they're able to provide informed consent. You know, you do get into situations where they may be in a more of an institutionalized setting, and even in independent care or an assisted care, and you know how that affects the study. We have studies like that being done, and one of the issues is getting buy-in from the center to be able to let the studies be done in their center, and people are able to make it to visits and those types of things. But I can't think of any specific situations where we've required certain requirements for older adults.
So then the one sort of question I was going to do before I kind of put us into sort of summation mode was, this is really kind of an inside baseball question for single IRBs. One of the things that I think is sort of interesting is, as a sponsor of a study that's under single IRB review, I'm speaking of me as a sponsor of a study that's under the oversight of a different single IRB than yours. Mm-hmm. We can make sort of requirements that there's a large portion of the consent form is locked down from an equity perspective, so that people across the country are really getting national language. Whereas I know that in other situations, a single IRB allows many of the local IRBs a lot of tweaking of language in all of the sections of the IRB or of the consent form. And I guess if you wanted to comment on, to what degree is it a problem that the language in a consent form for a study might be different in Ann Arbor and Cincinnati, knowing that every investigator is going to explain things slightly differently, but in terms of using different language that's still getting the main points apart, I guess, how do we reconcile that people might be interpreting things slightly differently because they're getting actually different language at two different sites?
Yeah, I mean, that was one of the reasons why moving towards a single IRB review of the multi-site studies, to make the consent forms more consistent. You know, if things are presented in a different way and people have a different understanding of that language, it could impact mainly, you know, their decision to enroll, you know, whether or not they're going to enroll. You know, we are a little more lenient than some networks in terms of revising consent forms. That may have been a mistake when we started, but we have been a little more lenient. But in general, those are in areas that are not more of the meat of the consent. We really try to keep the risk section the same. Description of the procedures sometimes can change a little bit because of different standard of care, different ways people do things at sites. But I think the real reason we want to keep them consistent is just the efficiency of the review process. And yes, we all can say things differently. Every IRB writes the best consent form, but realistically, if we're saying things in standard, simple language, it should suffice for all of the sites. There is the talk of local context. It's something the IRBs are supposed to consider during review of studies. What's appropriate for their local areas, but realistically, for most things now in the United States, we're fairly homogeneous in terms of what goes in an informed consent document for medical research. I mean, there are some state requirements related to surrogate consent and some institutional requirements related to types of different Catholic hospitals have certain things. But, in general, I think that the language and consistent language in the consent form just makes it so much easier from site to site.
Great. Well, thank you so much for joining us here today. I think just some of the key points that I would like to make. First, in the chat box, Joy has put the evaluation link for the webinar. So if you're seeking CME, that would be where you would go to click on that and fill out the evaluation. But even if you're not seeking CME, we really look at these comments and help to tweak and design and improve our next webinars. But I think, key points I think to think of when doing IRB applications and planning study procedures for screening, consent, and enrollment in neuroscience trials, to, I think, engage your IRB if you have concerns or questions. The IRB regulatory analysts up to the chairs are extremely knowledgeable of the regulations, and better to ask a question than just submit something and hope for the best, because there will probably be more back and forth. I think IRBs tend to appreciate that, and sometimes it needs to be a two-way conversation. People can still talk by phone these days. If you have concerns that accumulate during a trial, be sure to keep your IRB in the loop. And I think that, the third point is be mindful of your study procedures and what potential ethical issues there are. Think from what's in the best interest of patients, knowing that there is a balance to the patients in your study, but then the future patients, and that, how the study is going to contribute to learning that's going to benefit both groups. And Dr. Linke, any other key points that you want to take
the
away
idea of keeping your IRB in the loop. I've been involved in IRBs now for over 25 years, and the biggest change I've seen is, there used to be kind of this adversarial relationship between IRBs and investigators, and that's really gone away, especially at large academic health centers. The IRBs are here to work with the investigators, and it's a collegial relationship, and truthfully, working with investigators on their protocols is one of the most interesting parts of my job. Actually working through these things. People want to do the right thing. It's just complicated, and especially if you're not doing it a lot. So, working with your IRBs, I think, is really the best thing.
Right. The goals are aligned. Protect patients. Be compliant with regulations.
Yeah.
We're resources and for each other and partners, and we should work as partners and not adversaries.
Right.
Yeah. All right. Well, with that, we will adjourn 5 minutes early. At least you have time to stand up and stretch before your 1 o'clock Zoom call. But thank you so much for attending. And again, it was a pleasure talking to you today.
Thanks, William. Thanks for setting it up, Joy.
Thank you,
Bye,
everyone.
everybody. Bye-bye.
Take care.